Assalamu alaikum wa rahmatullah. Bismillah ar-Rahman ar-Rahim. Welcome to MEOM webinar meeting. And today also, as usual, we are having an eminent speaker from as a global meeting. And we will start with the first part. We will give a talk. I will give a talk, then Dr. Hassan, then Dr. Nadeem. Then we'll have surgical cases by Dr. Salam and Dr. Georgoka and Dr. Suzanne Texer. So I will start sharing my presentation. I cannot share, Abdullah. Okay, now, okay. So my talk today, it will be about photon in the DME approval for using an Eylea 8 milligram. Before we go to this, we want just to highlight some points about diabetes. And diabetes, as you know, is a growing worldwide epidemic affecting the working age of populations. As estimated, it was in 2019, the number of population that having a diabetes mellitus around 2000 and sorry, it is around 430 and 63 millions. And if you can see, it will be increased, or you can say in a 50%, it will be increased in 2045 to 700 millions. Also, this one, it will lead to an economical impact and burden on a healthcare system, and it will be raising from 760 in 2019 to 845 billions. Also, this it show increase worldwide, not only in a certain area. It will be shown some area. It is more than 143%. They will be like in Africa, and some area in the Middle East. It will be around 96% increase in the number. Some area it will be 51%, and so on. So there is vary from one area to another area, but it is increasing all over the world, and is making this as an global disease with an economical burden and high number of people that or populations that are affected by diabetes mellitus. In United Arab Emirates, in the last survey about 16.3% in 2019. Before that, it was to about 20%. That means in 5 patients, then 5 people or 5%, there is 1 person is having a diabetes mellitus. There is a problem that's when we are talking about diabetes mellitus and we are having everyone diagnosed in the first time of diagnosis, the first things come to his mind, he will lose the vision. And it is really a problem. That means we are having something in our mind to help these people because these complications that will happen. And they are forgetting all others because the fears of loss of visual acuity is important when the people getting diabetes mellitus. What are the current anti-VEGF therapies for NMD or DME? We are having many, as you know, in the latest 20 years. We are having many anti-VEGF that raising in the market, and they are having a different, either FDA approved or so on. Some of them use as an F-label, and others are approved, but with different type of actions and so on. And the latest one, which is at the aflibercept Eylea 8 milligram, which was in 2023. What are the factors influencing the treatment selection? This is also a very important slide. I want everyone to concentrate. Disease characteristic, that means there is a severity of disease, the response to the previous medication or not. Patient-specific factor, this is very important also. If the patient adherent to the follow-up, or there is a financial constraint, and that means they are able or they have an ability to get these medications. Safety and efficacy also, systemic risk factor like cardiovascular risk and potential adverse effect of some medications. So in the recent years, we know there is an emerging breakthrough, including innovative treatment options while we are using anti-VEGF or we are using a steroid. With this advancement, the future of DME and AMD management is looking brighter, providing hope and for a better quality of life for those affected by the sight-threatening condition. But even with this advancement in the management, we are still having challenges in the management of DME and AMD. And this can be in 4 categories. Either some patients, they are not responding, and we know around 40% of our patients, they are not responding to the anti-VEGF. Some of our, or most of our medication that's available in the market before the era of Eylea 8 milligrams, the durability is very less. And that's why I think the new molecules, they are looking to tackle the durability of the medication that are giving in for the treatment of DME. Also, the efficacy and safety is very important. Economical burden also is very, very important. We need, if we are having more durable, that means we are decreasing the number, and that means we are also improving the economical burden on the patient and healthcare system. And compliance of the patient also very important. If we have a multiple injections, the compliance, it will be very less. But when we are having a less frequent of injection, that means we are improving the compliance of the patients. The treatment evolutions of the diabetic macular edema and AMD while using the medications, you know that we are in the early in the beginning of 80s, we are using only the laser as a gold standard management. But then we go to triamcinolone and we are using it as an off-label in 2001. And the era of the anti-VEGF started in 2006 by the Avastin, which is also used and off-label and still until now used even in advanced countries. Some of them, they are using about 40%, as I know in United States, still using Avastin. After that, we start having a molecule that FDA approved, EMA also approved for using to management diabetic macular edema, starting by Lucentis in 2011, 2012, then the era of the anti-VEGF, the Iluvien, it came in 2012, then Eylea and Ozurdex, Eylea 2 milligram and Ozurdex, it came in 2014, Percimab, it was into 2022, and finally we are having the Eylea 8 milligram. It was in Europe in 2023 November and United States in August 2023. So if we go now to the photons about talking about the 8 milligrams, you know, Eylea 2 milligram, it was a great and having a very good effect on the management with a good safety and profile safety. And now we are having a greater, which is the 8 milligram. What are the benefits that we can get in when we are talking about the Eylea 8 milligram? It is, if we look to the vision, lasting vision gains is very important. Vision gains maintained with extended intervals. Treatment intervals, we are reaching up even to Q16 and 20, and now maybe to Q24, that will be mentioned by Dr. Hassan as an extension for the management of diabetic macular edema. Fluid control, it has a very rapid and resistant fluid control. So photons, if we talk about photons, the study of the photons, this is the randomized clinical trial double mask, and it's comparing the aflibercept 2 milligram and aflibercept 8 milligram, but is given Q12, then aflibercept 8 milligram that given Q16. And they have do a comparison, and there is a primary endpoint and in 1 year, and the second year, it was the end of the study. And there is now an optional 1 year open global extension until week 156. So the best corrected visual acuity, it was shown there is no difference in the visual acuity improvement if we are using either 2 milligram Q8 or if you are using 8 milligram, which can be used Q12, or if we are using an 8 milligram Q16. And if we are looking here, then we will see that in 1 year, you will find there is an improvement in the visual acuity. But what is the gaining, or what is the benefit of that? We are decreasing the number of injection, and you can see how it looks like. I will show in 2 years, it will be showing the number of injection. In Q16, we are having around 6 injection in 2 years. In Q12, we are using only about 8. And in Q2, we are having more, which is around +7 or in 60. So number of injection in 2 milligram, around 14. In Q12, it's about 9.5. And if we are using Q16, we reach up to 7 injection in 2 years. Also, there is an improvement, sure, in the central retinal thickness, improving in all lines of them, either 2 or 8, 16 or 12. And there is a reduction of central retinal and maintained within the 2 years, but with less injection if we are using Q16, the 8 milligram Q16. Mean number of injections that we already mentioned now, just we mentioned in 1 year or 2 years. Also here in 2 years, number of injection. And here we are seeing that those they are using Q12, some of them they are in the next year, it will be going to 93% or 47%, they are going to Q20. So from Q16, which is 88% of the cases, it will go from those they are using Q12, by 47%, it will reach. That means 93% of the cases, they will go in Q12 and the other one Q20. From those, they are only used as a Q12. From the safety profiles, there is no any difference from the safety profile from 2 milligram or other medications. It is either we are talking about the ocular or in the systemic. No cases ischemic optic neuropathy were observed also in all cases. Also, we are having also vasculitis or others. We don't find any vasculitis cases. Also, the intraocular pressures, doesn't find any problem with intraocular pressure while we are using 8 milligram, either Q16 or Q12. And also this is the systemic side effect. It is the same. There is no any significant complication or in the safety profile with systemic effect. This is the box of Eylea 8 milligram. So here we are using the Eylea, you can see, and it is 8 milligram or 4.3 milligram per ml. And we are giving in this here 0.7 millimol. We are not using like before 0.5. It's very important to know. And it is little strong, so you have to tighten the needle very nicely so that it cannot be have a problem when you are giving the injection. I would like to thank you. And if there is anything, we will discuss, inshallah. And this is an invitation to 8th MEOM that will be in Dubai in 30th of October to 1st of November 2026. And also for anyone who wants to join us, either expert or young ophthalmologist, he can join and do an abstract submission that we have done an extension of or we extend the deadline and become till the 30th of June 2026. Thank you very much. Nazim?
Yeah, thank you, Dr. Mohammed. So we will go to the 3-year extension study of Photon, which I welcome Dr. Hassan Hassif from Dubai Hospital. He is a retina consultant. Yeah, Hassan. go ahead, then we will discuss at the end.
Good evening, and thank you, Dr. Muhammad and Bayer, for the kind invitation, and it's my honor to be with you this evening. I will speak about, as Dr. Muhammad mentioned, about the key results from the photon extension. And as you know, that the photon is a comparison between 2 milligram and 8 milligram in the two intervals, 3 months and 4 months. And the extension is that in the end of the photon study, the patient gives the option to enter to the 1-year extension of this photon study. And the difference in this extension, that all patients will receive 8 milligrams, and all patients who were already on 2 milligrams, they will be switched to the 8 milligram, and directly it will be interval of 12 weeks. And the start of the photon will be from the 96 weeks, and it will evaluate the visual acuity and the thickness, or the reduction in the retinal thickness of the patients. As you see here, that the design of the study, that all the patients, as mentioned, that will receive the 8 milligrams, and evaluation mandatory for these patients who switch from the 2 milligram to 8 milligram will be every 4 weeks for the first 3 visits. Then it will be go for every 3 months. And the patient who already was on the 3 month or Q12 or Q16 on 8 milligrams, they will keep on depending on their last assigned dose. And as you know, that the extension dose regimen modification, and the 3rd year will be shortening by 2 weeks, and the extension will by 2 weeks, not as in the photon will be every 4 weeks, the extension. And this is the criteria for the extension and the shortening, because for us, maybe sometimes. And about that, the distribution of the patients was around, with the patient who completed the study, around 80 patients, and who enters around half of the sample from the photon. And the distribution of the demographic of the patients, about the age and the race, was comparable between these patients. And if we evaluated the mean change in the best corrected visual acuity, we can find that the patient already the gain of the number of letters around 70, which in the end of the photon continues in the photon extension. Here you can find that the patients keep on this improvement, and the number of letters around 8 number of letters, this is an overall. If we go for further and we distinguish between the 2 doses, and if you look at, as Dr. Muhammad mentioned, that the patient in the between 2 milligram and 8 milligram in the photon, there was number of injection around 14 for the 2 milligram and around 9 for the 8 milligrams. And when you can find when the patient is switch from 2 milligram to 8 milligram, you can find that still, in spite of going for the 8 milligrams, the number of letters around the same, the gain of the number of letters the same, keep continuous the same, and the patient receive less number of injection. You can find that the patient who switched to the 8 milligram received around 4.4 number of injection, and compared by the patient who already on 8 milligrams, they receive around 3.3 injections. And this is reflected on the decrease in the retinal thickness. You can find that the CRT was dropped from around 450 by the end of the photon to reach around 290, and it's continuous in the photon extension, and it will reach around 270 microns, and the patient have reduction in the number in the central retinal thickness around 190, and by the end of the photon extension. And this is a very important slide, because this is going to compare the response of the patient who already was on photon and 2 milligram, and you can see the sawtooth pattern for this patient between the dosing and the end of the photon. And when the patient just received the first injection of 8 milligram, when switched to in the photon extension, you can find there is the reduction a huge reduction, around 50 micron in the after the first injection, and again reaccumulation of these edemas, or it was take time around 8 weeks because of maybe of the related to the duration of action of the 8 milligrams compared by the 2 milligram, and this efficacy is continuous until the end of the extension. You can find the patient reach here around 266. So the reduction of the mean reduction in the central retinal thickness around by the end of the extension around 210 micron. And about the patient, the last completed dosing by the end of the third year, or 156 weeks of the photon extension, you can find that in the group of the patient who already was on 8 milligrams from the start, you can find around 45 of the patients reached the Q20 as on last completed dosing interval by the end of the photon extension. And again, around 48% of the patients reached the Q20, and they were on the last assigned dosing interval by the end of the photon extension. And going to the patient who received the 8 milligram in the extension, you can find around 83% of the patients was reaching the interval around more than Q12 by the end of the extension, photon extension. And about the safety, as Dr. Mohammed mentioned, between the two doses of this medication, there is no ocular safety profile was normal, no occlusive vasculitis, which is very important for us. And again, for the non-ocular safety was around comparable between the two doses. And in the end of this summarizing of this extension for us is that switching from about the efficacy of the medication, you can find that the patient who received 8 milligram from the start, they keep and maintain their gain in the visual acuity and anatomical improvement, and they around 45 patient or 48 of the patient reach Q20 by the end of the photon study, photon extension. And if you go in detail for the 2 milligrams to switch to 8 milligrams, we found that the improvement, the vision improvement, which we gained by this 2 milligram, continue after switching the patient to the 8 milligram, and around 83% of the patients they reach the Q12, more than the Q12 by end of the photon extension. And the longer of action of the 8 milligram, it was cleared after switching the 2 milligram to 8 milligram, especially in the first injection in the beginning of the photon extension, and the reaccumulation take time around more than 8 weeks. And this is given evidence from this study that the duration of action of the 8 milligrams is better than 2 milligrams. And I will not speak about the safety, which already explained by the photon and photon extension. And I wish that I summarized this study very clearly. If there is any question.
Yeah, thank you, Dr. Hassan. So what we will do, I will go to my panel discussion, then we can discuss it. Okay?
Yeah.
Yeah. So I will share my screen. You guys can see?
Yes.
Yes, doctor.
Yeah. Yeah. So I will just summarize what we all discussed here regarding what Mohammed spoke and what Dr. Hassan spoke. Is basically the study purpose is already outlined here. Both of them spoke. But what is important is that when we do this photon evidence 1 to 2, what is the implication in our retinal practice? That is how we extrapolate data into our real life practice, seeing a science being how it is practically applicable in our real life, where the environment is absolutely uncontrolled. So if you see, because non-inferiority based corrected visual acuity versus the 2 milligram, what it shows that how the study was designed. Okay. Now, this shows that up to Q24 week in 30% of the patient subset of patient requires only 2 to 3 injections per year, which shows that there is a compliance you can expect in these patients. Even though the CST reduction, remember, the study shows that it dries initially, but it maintains above the level below 375 micron, which shows this is again durability driven study. It is not a dry strategy driven study. So that is what you can maintain it. The implication is that you can extend the injection interval. So the photon 3 shows us that durability can be maintained for long term and the vision can be maintained at the end of 156 weeks. And some subset of patient can also be extended to Q24. So in real life, we need to apply that based on our OCT and visual acuity and to see which subset of patient can be extended at Q24 or Q16. In a patients where in real life their glycemic control is not good, their compliance is a big issue. So, however, having said that, these two studies shows that the injection burden can be reduced in the patient who comes to a clinic. So we have more important acute patients to treat. So going into that, so the highlight of these two studies is durability. Second is the clinic flow. So we can accommodate more patients and make these patient visits more longer. However, patient selection is important, especially in poor compliance patient, chronic DME, and all those stuff. And treatment strategy, I again say, it is not treat to dry, but treat to stabilize in order to extend. So that is what this study showed. The study doesn't dry the macula. So 3-year study data also shows that we can have a sustainable extension. Okay. However, in real life practice, we need to monitor this patient. But the importantly is the patient counseling, which we'll take from this, that we can be able to counsel our patients. If you go through this extension study, probably you might need 4 to 6 months interval injection alone, increasing the compliance of the patients. Now, based on this, I'm putting some question to our panel. Number one, photon shows excellent durability in the first year as well as the 3-year extension. How will it change your overall treatment philosophy for DME? Anyone? Hassan?
Yeah, for us is that this is give us that 8 milligrams as the rule now to give the patient for better response in the first treatment. Then the extension, which will be more control, even for in the photon extension give us this is that for this extra 1 year, around half of the patient can reach more than a Q20 or Q24 as you mentioned. So it's approved the rule of this medication for us that to reduce the visit, as you said, and the patient has the better response on the medication.
So overall, in your patients in your clinic, so will your approach now change knowing this data?
For us, our approach changed since the first to get the approval, the 8 milligrams. We don't use any extra 2 milligrams. All of our use now it's 8 milligrams, and we are satisfied from the medication, and we don't report it any safety issue, and we have a good result. And we reach some of the patients we reach around Q20, and we wish that we reach the Q24 for the patient. Still, the patient the medication with us since more than 2 years.
Yeah, that is the ultimate goal. Thank you. Now, my next question, anyone who wish to say, 3 years data shows that once the patient reaches Q16 or Q24 weeks, do you think how it should influence you to do the extension study, extension interval in the first 12 months or 1.5 years? Will you be more aggressive to extend on the first year? When will you start to extend? Yeah, Mohammed.
Yes, I think this it will be depend. If we get a good result when we give the medication in the beginning, in the loading dose, then we can go and extend. Why not? And we can keep close monitoring. Either we can go directly to Q12 or we can go directly to Q16. And this depend if the patient is following very nicely and he is a good control of diabetes mellitus and he responds very well in for the 3 loading dose. But if not, then it will be very less. I will not go directly to the Q16, maybe to Q8, then we go to Q10, then Q12, and slowly, slowly, this according to the response of the patient and how is the patient responding.
I think you have rightly said.
Yeah,
So even though
yeah.
study says that we must individualize the treatment to a patient because especially because diabetes is uh, depends on many uh, confounding influence on the control like glycemic control, compliance of follow-up, whether the patient understand the mode of treatment. So, and also will based on your OCT features and the visual acuity decline. So I think it's very important, as you said, that we have the data, but it has to individualize to each patient's how they go. And thank you. I have one more. In the real world, compliance is a major challenge. Do these photon long-term results justify using 8 milligram as a first choice for patient with poor follow-up? What do you think? Does it justify to be used in patients who are
I
non-compliant?
think I think I mentioned in my presentation that there is a challenges, and one of them is the patient they are not adherents because of the so frequent of injection and follow up. So if we are having this kind of durability and good extension, that means will give us a chance. The patient will be more adherent and they will get a best result of using this medication.
Yeah, Dr. Susanna, what's your experience?
Well, it's a very good experience with using the 8 milligrams. Almost my patients with diabetic macular edema, if I do anti-VEGF, I use the 8 milligrams. Now, if he's very well, like Mohammed Ali said, if they are well controlled, I can widen, but not suddenly from Q8 for Q16. So I go it slowly, the same way, slowly, but I'm using more and more the Elia 8 milligrams, no doubt, with confidence. I mean, we begin to understand how he speaks, how we speak with the drug, and as soon as we have some kind of confidence, I think we can switch steadily. We can easily switch to 8 milligrams with confidence. That's my experience.
Thank you. Actually, my personal experience is the same as switching to 2 to 8 and increasing the durability and the interval of seeing those patients.
Yes, and in a naive patient, I use already 8 milligrams. I don't begin by 2 milligrams.
Yeah, so, but what I do is I extend every 2 weeks instead of extending, very carefully.
Yes, and I'm sure I like to see the patients and to maintain a good contact with the patients. And they like to be sure that everything is okay, that the doctor is there and is doing the best. So we can confidently show them that we can go farther, you can widen the appointments and widen the treatment safely. So to me, it's important to go step by step.
Yeah, thank you. So my last question, looking at both these photon data sets, in your experience, in your real life, which do you think will benefit most from this 8 milligram? 1 or 2 words. Anyone?
So what is that? Do you mean I didn't get the questions?
The question is that with this 8 milligram, which subset of DME patient you think will benefit the most?
I think all the patient can benefit. Anyone, you cannot select like this, but I mean, switching now is a good one. If you are having a patient not responding, I think there is a chance to change. Those they are not adherent and they are not good follow-up, so they are going to benefit because they will be more durable of this one. I mean, it can be the first choice for any patient if you want to go in this board. It will be very simple.
I think we have a poll question for this one, so anyone can choose an answer. If
Yeah,
Abdullah
that is
can
there
help
at
me.
the end.
Minna, let us
That is there.
Susanna, she will connect, then we will go to the question from outside.
Yes, it's the same question.
This one is the question. You can put the poll, Muhammad.
No, ball is the end.
Yeah, this is the end question.
Okay.
Oh, we cannot vote.
Well, I think
Panelists cannot participate in the poll.
Yes, I think the host should open the vote option for us, please.
Abdullah.
Okay.
ما كانش حد عنده علم بالموضوع، عشان كده كان لو send from the earlier.
Okay, anything?
طيب الانسر يا محمد. What is the answer? Okay, Abdullah, did you get any result? If not, we can just have our opinion and then we can close.
Yeah, we can have an opinion.
I can't when I open it, I can't edit.
Okay, مش قادر يعمل editing. طيب ماشي. So what is your opinion, Dr. Nadeem?
Yes.
All
Yes,
naive patients for me.
I think it makes sense. It will become a new standard for sure for direct macular edema,
Yeah.
no doubt. And as a naive patient, as some switch to treatment switch, but as naive patient, I think it will be the new standard. That's my opinion.
Okay. Can we stop the Abdullah the poll? Okay.
So that's my part.
Okay, thank you very
Thank
much.
you.
So you can continue now with the surgical cases. If there is no any comment from anyone, any else want to comment our presentation? Okay, so we can move to the second part, and you are going to control this, Dr. Nadeem. Our first speaker, Dr. Salam, is here.
Yes, thank you so much for the kind invitation, and I would like to invite everyone to come to the MEOM meeting in end of October, early November. We'll be there, and it should be a fantastic meeting. I had like, I was not sure really what to present. I had a case which I think is very interesting, especially for those who do combined surgery, cataract and retinal surgery. Let me show you. It's very simple, but it can actually make your life easy or difficult, depends on how you feel. Let me sorry, I had it there. Okay, let me just share the whole screen.
Yeah, we can see what's up.
What's up? Yes. Okay, here's the case. And this is a very interesting point. So I think when you combine versus non-combined cataract retinal surgery, what I do is I try to avoid combined surgery. My only surgery in a way is epiretinal membrane, which I tend to do combined surgery. The reason is usually don't use gas. It's very simple surgery, and it just finishes quickly. Otherwise, I try to avoid combined surgery. I think you get more inflammation, especially if you put gas in, you get lens decentration. And a study we did found actually 9 times more chance of needing a lens surgery like IOL reposition or change or cutting synechia with combined surgery as compared to non-combined surgery. Anyway, let me show you what, sorry, the screen is on. Yeah. Let me show you this. This is a case of a combined surgery after all what I said. and we did the cataract, right? And here, and the IOL is centered. But what we usually do, we put at least one trocar in, if not the 3 trocars. And then after that, we start the vitrectomy. And as you can see here, we put the remaining trocars and the infusion. And then you can see here, once you open the infusion, the AC is shallow. So sometimes taking a stitch helps, but sometimes even without a stitch, it doesn't help. Here is the trick. This is the trick. The trick is you need to stop the infusion and then do a dry vitrectomy. But the problem is, if you try to do this, the machine would refuse to work. The reason is if the infusion is off on the machine, the vitrectomy is not going to work. So the trick is actually to trick the machine by doing this, by keeping the machine on and clamping the infusion. And then you do the vitrectomy, a dry vitrectomy, just enough so that the cornea starts to fold. And then after that, while the infusion is still off, so here you see like AC shallowing and the eye is getting soft. Then after that, you get the instrument out and you form the antechamber and adjust the lens and do all the things that you want to do. And then after that, you pop the infusion back on again, and then you complete the surgery. And then the AC usually would remain deep. But I think the trick is you have to like soften the eye. And the way to do this is you have to clip off the infusion rather than switch it off on the machine. And then you go to the posterior segment and complete the surgery. So that's all what I wanted to share.
So doing the combined surgery is never your choice.
No, I don't like combined surgery.
Yeah, please go ahead, Susanna.
I am the yes, because most of my surgeries are combined surgery. I do a lot of diabetic. I do a lot of diabetic that already have cataract. I do a lot of retinal detachment. And the only way I can shave everything and shave all the adhesions and the anterior part of the pars plana and the anterior part of the vitreous is making indentation and go to the anterior part. Then I am sure I don't have tractions because usually it's a rhegmatogenous detachment. So what I do in order that doesn't happen, I do one stitch to the main incision. At the end, I can take it or not, but I don't have this kind of problems. 2, if I put a gas, if I am expecting to use gas as a tamponade at the end, what I do is a most narrow anterior rhexis in order that I am absolutely sure that the lens is not subluxated or luxated through the anterior capsular rhexis. So in my experience, I don't have this kind of problems because I give a stitch and hydrate the lateral port side. So I can make indentation freely without having problems with the anterior chamber. So I use most of my surgeries are combined surgeries.
Yeah, do you get any lens problems or posterior synecdoche or no?
No, nothing.
Yeah, I think
because
yeah,
I always have a steady chamber. Never have a subluxated lens because you can have inflammation when the lens come anterior to the anterior rhexis, and then you have inflammation. I'm always having a steady bag, so a steady anterior chamber. I don't even I don't use almost never C3 F8. I just see F6. So I never have this kind of problems.
Yeah, so I think this is always a debate. Talk to people who really like combined surgery. Their point is they never have any IOL problem. And if you talk to the people who don't like combined surgery, you say we always get IOL.
You always have, but I changed this, because I do a little. The anterior rhexis is not so wide as I used to do in cataract surgery, in order not to have this kind of problems when I'm working and let the tamponade after the surgery. But really, I don't. Now, surgery is an art. a good technique for me is not a good technique for you. Do you understand? So this is the good technique in my hands. That's why I was telling I do all the time, or almost all the time, combined surgeries.
Yeah.
Yeah, so I think because Dr. Susanna, you do your own cataract. Yeah.
Yes, I do.
Yeah.
I'm doing everything.
Yeah.
No,
For a person like me who does only retinal surgery, I don't know how to do cataract. So I, yes. So so I take help of my cataract doctors. But yeah, when they do it, when I really need to do a combined surgery, I ask him to put a Keno nylon stitch on the entry point.
yes,
Yeah. And then I go ahead with the surgery. However, having said that, if the cataract is not that much and I can see and do my job, yeah, then I go ahead and do my job. But if I cannot, I know it will obscure my vision during my surgery. Never. I do a combined surgery. So it is not always the rule, but is a corollary to the rule for me. Okay. And number two, in diabetic vitrectomies, I mostly use air if I don't create anything, or otherwise max SF6. If I do a RD surgery, I rarely use C3F8. I mostly use SF6. Okay. Unless, it's an inferior detachment PBR, then those are different stories. So yeah, I think what suits best in you, it is not always the rule what you do, but you always have an option of doing or not doing based on the case. But the tip is good that what you said, that if you make a small anterior opening so the lens stays in place, I think that's a good tip. And I like the other one, which I used to do during 20 gauge. They put the cannula first before before starting the surgery instead of pressing it when after the cataract surgery. And that's a good thing I saw in Ahmed. Yeah, can we go with the next one?
Yeah, Dr. Susanna, I think.
Oh,
Yeah,
it's
Susan.
me?
Thank you
Yeah.
so much.
Well, this is a very hard thing for me to do because do you see my?
Yes.
Yeah, clear.
Well, this is a case that it's not really a retinal case, but it's a complication that the retinal surgeon had to solve. So this is a case of completely different from what he said we were seeing before. This is a case of young boy that had blunt, an open, blunt trauma, a rupture with this huge corneal wound, and became after this trauma became without aphakic, so without chrysalians, and an iridic, so without iris. So it's very frequent in those kinds of traumas with ocular rupture. The only problem is how are we going to solve this problem? I mean, put an iris and simultaneously correct the aphakia. A few years ago, before the war, Ukraine war, there was a wonderful lens with 3 supports from Russia with the lens and already the iris attached to the lens. But after the beginning of the Ukrainian war, we, at least in Portugal, we no longer have this kind of lens. So there become our problems. How to solve the aniridia and the aphakia of a young patient. I was studying, asking colleagues, and I decided to use what we have nowadays, that is the artificial iris of human optics, and we have the Carlevale lens. And I had it's not my idea, but I think it was the ideal for this young boy to have an Carlevale lens with a iris stitched to the Carlevale lens. I think it was really a good idea. I spoke with a lot of colleagues how to do it, and I decided to do it. So we first measure the cornea, limbus to limbus, to be sure really what's the size of the trepanation of the iris. Then I use a scleral flap to protect from erosion of the lens. Then we decide to cut the iris and to stitch the lens, the iris to the lens. So that's how it works. You have the lens, stitch it, and now I'm going to stop here because it was a nightmare surgery. It was one of the most difficult surgeries I've ever done in my life. So I had to do the vitrectomy because of it was a blunt case, but everything was okay with the retina, and then began. So there are two ways to put this kind of lens and iris inside the eye, with an injector and opening the cornea. So like in all the surgeries, the wound, the easiest way to manage things. So I asked my colleagues that already used the injector, and they found it very difficult to use, so advised me to open the cornea in order to be able to most easily manage this kind of iris and lens. And I did it. So I did it. Oh, sorry, I must go. So I decided to open the cornea. I fold the lens and the iris, and that's the problem. So I stopped to have a formed eye. So it was wide open, and it was very difficult to maintain and manage the instruments inside the eye, even with the infusion open. So it was very difficult to put the cornea, the sclera has no longer, you see, as elasticity, and it was very difficult to do it. And the great problem was I grasped already the aptic, let it, so it was safe. To me, it's very easy to take this aptic off and look at me. A difficulty that was to take the first aptic outside. The eye, its elasticity, as it was not a conformed eye, there was no elasticity. Then I was trying to slowly take off the aptic, and boom. So my nightmare began. I had the lens without the aptic. I had to go inside, take off the lens, deep breath, to pray to all the gods I know, take off the lens, and do it all by the beginning. So it was really a nightmare to me. I had to close the eye, then to suture again the iris to the lens. As you can see, just one of the optics is there, so it was not a safe lens to that inside the eye. Again, do everything. Take a deep breath. As you can see, it was a long surgery. Then I widened the opening in the sclera. So I did enlarge a little bit the opening to put I don't know, I don't remember to take it. That's the usual. It came out. That's how it usually used to work. So you come out, you have one aptic, then the other one, so everything is safe. Okay, then I decided to widen the openings of the sclera inside the eye to be able to take the other aptic from the other side. So again, it was easy to do it as soon as we can enlarge this sclerotomia. So it took off and everything was okay in one side, in the other side. So that's the end of the surgery. But it was a nightmare to me. I still have tachycardia when I remember this. 1 year later, the iris is there, centrated, and the vision is not so good as it would expect, but it's because of refractive problems of this scar in the cornea. So that's my case. What I learned about this case is that I usually use a 23 gauge and enlarge a little bit the sclerotomia where the forceps come. In this time, I use a 20 gauge to be sure that I don't have this kind of problem taking off the optics from the sclera. So, okay, that's the end of it.
Yeah, that's a wonderful surgery. So you have
You
guts.
don't remember. It was a nightmare. I learned a lot, but it was a nightmare to me, you know.
I think it's a wonderful reconstructive surgery, I would say, because cosmetically it is looking good, and the patient, whatever vision outcome, will not feel that bad glare, but at least some focus will be there. It's a wonderful surgery. Well done. Since I don't do cataract so much, I would ask George, you have any comments? Your experience
George,
with this,
how?
yeah, with NIRIDIA lenses and iris?
Hi, Nazim. Good
Hi,
to see you again. Susanna,
thank you.
I just
Hola,
see you
George,
2 days
how are
ago.
you? Yes,
I'm
we've been
good.
together.
I just logged in the middle of your surgery, but was a really tough case. You have a
Yes.
battle, and I didn't know that you have a lens with iris with the Carnevale
No, I
dispositive.
suture.
That
I suture. We once had a lens with three optics that
yeah.
already had the iris attached to the lens. It was a Russian lens, but it disappeared from the market. So now what I did was suture iris to the Carlevalo and then suspending the Carlevalo. But really, it's a very
Wow, great
difficult
idea.
surgery.
You
Very
you
difficult
suture
surgery.
what's yeah,
Roland,
but how because there is any hole anything in the Carnivale that you can put a
yes,
stitch
you have the optics.
because
Let me show you. This is how we do it.
oh yeah, the
So you
optics
have this
you go for the
Carlevalo.
optics and then
Yes, and you do
you,
four.
in the same
Yes,
device
four
you
sutures.
have two
Four
advantages
suture.
because you can use 4 sutures and then you have the lens
Suspension.
that's gonna refractions, a lens for refraction, and you include the iris in this lens.
Yes.
That was amazing idea. I love
But
this idea.
Very
Just learn
it's not my
how to
idea.
do
It's
that.
not my idea. It's not my idea. I use someone else idea. Yeah, Carlevale. I
But it's
asked
great.
Carlevale what's the best way to do it. But technically, let me tell you, Jorge, is very difficult. It's not easy at all. Because with the injector, it's very easy that the lens gets fractured inside the injector and the iris
Because
stuck in the injector. And I did the injection like this. I did the injection with a fold, like we usually to do with the lenses. So I folded the lens and the iris. But it's very difficult to manage, as you see. Very, very difficult. But my problem was to take off
yeah,
this
maybe
from the little hole. So I had to enlarge the hole. So my tip is you enlarge the hole, the sclerotomia where you put the forceps, enlarge to 20 gauge.
cornea sclera opening.
You must enlarge.
Yeah,
This
but
is the problem.
do you think that is one tip? The other thing that I saw, it's very hard to inject this lens fold in this situation because they are double. And then maybe you
That's
have
why,
to go inside the eyes open.
yes. My problem
then
is that the
you have
eye is
to enlarge the opening of the cornea sclera. You just open the cornea sclera opening.
Yes. So it's very difficult. So it's difficult to use the injector And in my hands, it's also difficult to open the eye and manipulate this way. So my advice is to widen this little sclerotomia, not to 23 gauge, but to 20 gauge, not 23, because I use a 25 gauge and then a 20.
It's going to be more easy to the Carnevale optic.
Yes, because if you enlarge this, then I enlarged it. It was very easy to take it because I broke one. So it was very easy to take the Carnevale with an sclerotomia of 20 gauge, not 23 gauge. So usually 25 forceps to the 23 gauge. No, it's a 25 forceps or 20 with a 20 gauge in this. You see, this is a 20 gauge sclerotomia. And look the optics. They are widely safe. They are safely outside the eye, and after, you see, 1 year later the lens is still there. So 20 gauge opening still maintain the lens and the optics grabbed in the sclera.
Okay, what about since it is already past injury eye, you did vitrectomy in this eye. So what about if you put a PFO, filled it up first, and then you go and perfluorocarbon liquid first, fill it up to the brim, and then probably that might help.
Yes. I think so, because I designed in my mind it would be easy to do this, but I forgot if I do a wide corneal wound, I would have not maintaining the conformation of the eye. So I didn't try, really. I didn't try at the time. I thought it was the best. I don't think it was the best. The limit, in my hands, the limit was the sclerotomia, very little, a very short sclerotomia, a very narrow sclerotomia that allow me to break the optic of the lens.
Okay,
so
George,
I still don't have the best solution for this.
I think the three things that I learned from you right now is we can use the Carnevale lens to include the iris, artificial iris, all together.
Yeah.
That's very nice. And the other thing that's Carnevale lens, you should open for 20 gauge instead of 23 gauge. That's going to be more
usually
easy
at 25
this.
With an opening of 23. No, make it 20. Make it 20. Less problems with the optics.
And maybe for this situation that has two items, that is the Carnevale plus the iris, maybe is to go inside the eyes, not fold, but opening. Just gonna be more easy. Just open a big corneal sclera.
That's a huge, even huger sclera. The ideal is to maintain the conformation of the eye. It's very much easier. But injecting this lens, it's not easy also. It's very difficult to inject the lens and not lose or the lens or the iris. But it's not yet, it's possible, as you see, it's possible to do, but it's not yet the best technique perhaps to do this. But well, I had to do it. And I had a terrible nightmare that day. I had a terrible nightmare.
It's a nightmare.
Yes, yes.
Okay, George. George, do you have a case to present?
Yeah, I have a case here. Just open it.
So I'm going to stop the sharing.
They are telling me that it's not possible to share my screen. You have to enable.
You can share. You can share now, Dr.
Oh, right now is okay.
I stopped sharing mine. I stopped sharing mine, so you can share now.
Yeah. Muhammad Awadallah, you are there?
Yes. You can see right now.
Hi, Nazim. How are you, everybody? Nice to see you.
Good.
Hi, how are you doing?
I'm fine. How are you?
And then I'd like to thank the MEOM and all my friends, Dr. Mohammed, Anhi, and Nazi, everyone that invite me to be here. Thank you so much. Just want to, this is my disclosure. And then my case, the endophthalmitis case, a 62 years old female diabetic pseudo-phakic, lost vision lost and pain 3 days after cataract surgery. Have corneal edema, hypopio, fibrin, and the vision was LP in the right eye. This is the picture that I have at the beginning of the surgery. And then I'm gonna just open it, the surgery for you. Was a lot of fibrin. A lot of fibrin in the anterior chamber. Have you seen that was so tough to remove all this tissue that was blurring my vision, and was the first thing to do, have to clean it out all this, because if you don't do that, it preserve inflammation in the anterior chamber. And after that, go very careful in anterior vitreous, and after that inside the eye. We should have be very slowly. The retina is very necrotic, and then if you make an anterior hole, you're gonna lose the eye at the first time during the surgery. At the end of the surgery, I just try to do a fluid exchange and to see well all the structures. And after that, I came back to fluid and inject antibiotic. And the questions nowadays to discuss about endophthalmitis is vitrectomy should be very early, or you should do as vitrectomy study guideline that you should first do antibiotics and tap biopsy for culture. The kind of tamponates, many times I use oil just because some paper says that it's no bacteria can proliferate inside the oil. And antibiotics, I use the standard like vancomycin and cefotaxime, but we should always do culture and antibiogram, because many times the bacteria are resistant for the standard antibiotics. This patient was resistant for cefotaxime, was Pseudomonas, and I have to use amikacin. And then you should be very careful with this. And then, just to finish my case and start the discussion, just invite everyone for the Brazilian Vitreoretinal Society meeting together with MEOM. I think Mohammed is talk too much, that looking for me. But anyway, thank you so much to invite me. It's open for discussion.
Thank you, George, for a nice case. I just have one question for you. Did you, before you do the surgery, you start the surgery, did you do before you go into the anterior chamber? Did you take a tap from the vitreous for culture and sensitivity?
Yeah. At first, I removed fragments from the fibrin tissue from the anterior chamber. Also, I took some fluid from the vitreous cavity to culture and antibiogram. That's the first thing to do, because we really need to check what bacteria we have and if they are sensitive, the antibiotic that you are using. Is the first thing to do before dilute all the vitreous and the anterior chamber. We should get some sample for that.
Right, thank you.
I think George now there is a modified approach to EVS study. So EVS study says that if you have a PL, then you go and do a vitrectomy. Now that has changed in comparison to that EVS study or endothelin vitrectomy study. So if you stay for so long, you may not be able to salvage many of the eyes. So I think the approach has changed now to go in early, than compared to EVS study, which was done in early 2000.
Yeah, this is a big debate right now about the right time to start vitrectomy. If you have a very bad visual acuity and it's not discussion that you should go directly for vitrectomy, but if you have that patient that has like 2400, 2200, many people think that the best way continues to be inject tap biopsy and inject antibiotic for 24 hours. If the patient start to improve, you should keep just inject antibiotic instead of go directly for vitrectomy. But this is something that we don't have right now a very good data that can be one versus the other. But the tendency of everyone right in the world is go early. But I'm not saying that you deny that antibiotic and tap biopsy still work in some cases. But I'm more for vitrectomy right now.
I usually when I see endophthalmic, I go to tap and inject first. The tap and inject gives me at least 24 hours time to look into my cytology, the microbiology, the gram stain, the KOH mount, and all this stuff before I go and do the second inject. So within this time, if I see that it is bacterial, then in my second injection, I might add the dexamethasone to if it's a bacterial purely, and then I have time to go think about going in and doing a vitrectomy. So, but the first instant, as a rule of thumb, is to tap and inject first. The tap is important to get the microbiological profile before you go in and inject blindly. But before in my setup, we used to do the tap and wait for 5 or 6 minutes before we used to send it to cytology and Grams and GMSA and KOH stain, and they will call and tell us, hey, it's fungus. So immediately we know what to do. But such facilities are not always available. So a tap and do the antibiotic inject and wait and see the slides and then go ahead with the next step. I think that's the safest way to go.
A second reason Nazim Al-Hussein has also in order to get tap and inject is easy to be administered and quick till we prepare for vitrectomy. Not all ophthalmologists have the leisure of having a retina surgeon nearby, or you need to prepare the room for vitrectomy, and you don't wait for this. You have to go tap and inject, and maybe later when you are ready, you can refer the patient or you go to the theater, but you don't deny the patient this important thing.
I agree. So I think the first initiative is go directly for tap and inject antibiotic. Even if you're planning for vitrectomy, many places is impossible to be so fast because we need to prepare the room, need to do many other stuff. Sometimes it's not room available for vitrectomy. And then if you are already injected antibiotic, we are already treat these patients. It's very important to be very quick. Don't lose time. And then in that meantime, you have time for planning for vitrectomy or for anything else you need to do. But tap biopsy and antibiotic is mandatory.
Yeah,
I think we all agree with that. My second question is, with such a hard endophthalmitis, as you see with membranes, all the anterior segment, to take or not to take the lens out, because the bag is a place where the bacteria, even with vitrectomy, even with everything, the lens, the bag is a place where bacteria can be. And you know that you can take all those membranes, but you cannot go behind the iris and inside the bag. So in that case, leave the lens or take the lens and the bag outside. Do you understand what I say? And I'm asking
I
because
agree with
many
you,
times
but partially.
I regret not to have taken the lens, you know?
Yeah, but sometimes the eye is so fragile to be more aggressive and take the lens. Sometimes we can have more complication. In this eye that's very bad in endophthalmitis, the eye is so fragile. If you make any more harm in the eye, you're gonna lose the eye, even if you cure the endophthalmitis. I agree with you in many situations to take out the lens and all the capsular bag is very important.
Mainly the bag, not the lens.
Situation was afraid. Yeah.
Well, it's not
the
a kind of be afraid. The problem is what to do after. Then, usually, if it's such a hard, such an advanced and aggressive endophthalmitis, usually I live with the silicone oil tamponade, because the principle, no oil, no space, no cells, is true.
Yeah.
So
the bacteria does not grow fast inside the oil. It's a bacteriostatic material.
And it's it's a little
papers
space.
said that you sometimes use oil is good for no proliferation of bacteria. And what to do if you need to re-inject antibiotic, half dose.
You can re-inject easily, even without changing the dose. So in these cases, let me tell you, I am very aggressive. I take off the lens, I take off the bag, I tamponade with silicone, I do injections at the end, and 3 months later, you can take this, if everything is okay, and then make a second implementation of the lens. In those cases, in other cases, just tap and inject. Okay, inject and tap, or tap and inject. And then sometimes just the injection is okay. Sometimes it's a toxic endophthalmitis. It's not a real endophthalmitis. So tap and injection, I think it's okay. And I think everybody agrees. Now,
I think also early cases, Susanna, they just you can do a vitrectomy and leave on air and gas. You don't need good silicone for a very early case. If you
no,
get
I said that's one difficult case.
Yeah.
That's very
This
aggressive.
is a relatively late case, yes, and aggressive as well.
Aggressive one. So
then,
it's maybe Pseudomonas, most probably.
Yes, because Pseudomonas,
it was a Pseudomonas, yes.
Pseudomonas is usually presents early and very aggressively.
Very
aggressive. In 24 hours can destroy the eye.
Destroy that. That's why I told you that one.
So what is George? What is the protocol in your institute whenever you discover a case of endophthalmitis in the OR? What's the protocol?
You have to check everything. You have to check everything. You have to check water. You have to check all the items that you use, like viscoelastic. Check the lens, everything. You have to really be very careful, meticulously check where they come from, because in one place they're gonna show up, or inside the OR, or anything that you use during the surgery. And then we should really be very meticulous to
they
check.
take cultures from they take cultures. Yeah. So Nazim, do you believe in the saying that most of the organisms are coming up from the patient himself, the eye?
Okay, before that, when it happens in the OR, it's a serious adverse event. And there goes an AER. So you have to do the incident report. It's not only that, you have to take swab from the surgeon's hand, then from surgeon's nostril, then yes, and from the patient, and from the batch number. We always write the batch number of the fluid that you used, the viscoelastic you used. So you have to check all the batch of that. So it is a very tedious process of doing, including the tubing and flushed and cultured, the cassette. That's a tedious process, and that has a process. That process is same everywhere. Yeah, and your question was what to me?
So the question, some reports says that most of the organisms are coming
from
from
the
yes, are like staph and things are
aureus.
coming from the yes, and pre-operative
Patients,
preparation of the patient, you have to check as before the lacrimal system and the things like
lacrimal thing which comes as strep pneumoniae.
right.
Okay. Staph aureus will come from your surroundings. Okay. Yes. But strep pneumoniae is the one who comes from the nasal duct. So yeah, that is already nowadays is known. I think the incidence of endophthalmitis has reduced a lot. I think I don't know now what is the recent incidence because I'm not a uveitis specialist, but I think it should be less than 0.1, but depends from institution to institutions and where you collect your data. So it might have a skewing of
Yeah.
data if you collect it from government hospitals or from a private
So the most
institute or
important thing you have to have a rigorous policy for whenever you discover a case in the OR, you have to go
absolutely.
through everything in a checklist, and it's a tedious, but I mean, if there is a policy and procedure that makes things easy and
Yeah.
done in,
Every hospital has got the infectious disease department. So you inform them, and the process continues with the staff and the administrative person. So the process is there in most of the hospitals. So that's how you do because it goes into litigation ultimately. So, but I want to thank you all for staying so late. Okay, not for Egypt or Portugal or Brazil, but your time are different. But I want to thank you all. And today is my wife's
thank
birthday, so
you.
I'll go and have dinner
Oh,
together.
congrats.
Oh,
Thank
sorry about
Okay.
that.
No, it's fine. I did my job. So we hope to see you all guys again. And thank you all for these wonderful
you.
cases. Okay.
Thank you.
Thank you so
Thank
much.
you.
Thank you.
We are.
Bye.
You have a nice.
Just a
Bye.
picture,
Good night.
picture. Don't go.
Okay.
Yes.
Thank you.
Send to us. Bye.
Thank you. Thank you, me.
Thank you. Thank you.
Ciao, Amari.